The study which we undertook was called the Aspirin esomeprazole chemoprevention trial, and the purpose of this was to actually look at the best ways of preventing a very incurable cancer called esophageal adenocarcinoma. So what we did is we looked for all the agents that might have an effect in decreasing cancer, and there's at least 20 of them, probably 40 now, and we also looked at surgical intervention with surgical ligation of the lower esophagus called Nissen fundoplication, and the two that came out by far the best were acid suppressant drugs, proton pump inhibitors, and indeed low-dose aspirin. So we looked at a 2x2 factorial design so that we could address these two agents independently, because that's the most efficient way to do that.
Just to clarify, that was high dose with aspirin, low dose, and low dose with aspirin.
That's correct. So the high-dose proton pump inhibitor, which is 40 milligrams twice a day, which is right at the high end of what we would normally recommend, and low-dose acid suppression, which is 20 milligrams per day, which is the standard routine dose of proton pump inhibitor. And then we used 300 milligrams of aspirin versus no aspirin at all. So there was effectively 4 arms in the study, 2 intervention, 4 arms, which would be high-dose proton pump inhibitor with aspirin, high dose without aspirin, low-dose proton pump inhibitor with aspirin, and low dose on its own.
Okay, and what was the duration of these treatments?
The duration of the study, the recruitment phase was 4 years, the follow-up was 8 years minimum, and a maximum of 10 years.
And when it came to the results, how are these bearing out?
So the results have shown 3 very interesting features. First of all, that high-dose proton pump inhibitor is statistically very significantly different from low-dose proton pump inhibitor at all the endpoints that we looked at, which were overall mortality, cancer, and high-grade dysplasia, but particularly in preventing the mortality, proton pump inhibitors seem to save some lives compared to low-dose proton pump inhibitors. And the reason that's important is we routinely recommend low-dose proton pump inhibitors as the norm. Secondly, with aspirin, the primary endpoint for that was not significant its own. However, when we looked at concomitant use of non-steroidal drugs, so anti-inflammatories, brufen would be the commonest, and we factored for when the patient started taking these drugs, because that was actually a protocol violation, and we knew in real time when these drugs were taken. So if we looked at the follow-up in these patients and stopped the follow-up and looked at the endpoints prior to them taking the non-steroidal drug, we then had a significant effect for aspirin. And what that suggests to us, as we already know, is that non-steroidals, certainly some of them like brufen, may very well on their own have some weakly cancer protective effect, but we wouldn't recommend people take them because they have so many other serious side effects. And then the last aspect, which was very important, is that all we've talked about so far is the benefits. For chemo prevention, it's very, very important to actually minimize the risks. And if you've got reasonable benefits but still reasonable risks, you can't use chemo prevention. What the third aspect of our study was is the risks were exceptionally low indeed. In fact, 1% of our patients had serious adverse events, which is much less than we expected. So I think what we've got out of this is we've got some encouraging data, but we can't give advice to patients individually at the moment. And my recommendations would be as follows, would be 3 things. Number 1, we've submitted our paper, which is for review in a major journal at the moment. We've already submitted that to one of my employers, the National Institute for Health and Care Excellence, for them to independently look over our paper and the raw data to actually see whether they think our results are right, because it can't come down to investigators or indeed investigating teams. It must come down to advisory bodies which are independent to come to these decisions. All countries should do the same. The second aspect about it is that we'd recommend that we follow up the patients for longer. It's very important to mention that we've looked for patients highly selected, pre-screened for adverse events to aspirin. We've been endoscoping them every 2 years to look for problems, so we've picked up problems very early on, and we've picked them up relatively young, so around about the early 50s. Once you start moving into your 60s, the side effects from low-dose aspirin increase linearly and in some cases exponentially. So it could be if you start taking your aspirin from your mid-60s onwards, we won't see all the low risks that we're seeing at the moment, so it's very important to be cautious. And last, I would say if you're the routine patient out there, you don't know whether you've got Barrett's, you have got Barrett's and you don't know what you should do, I would recommend you speak to your physician about it, because in fact we're very strongly encouraging patients not to self-medicate. This is a calculated risk. In fact, the big problem with chemo prevention, everybody's looking for low-hanging fruit, the magic bullet that can make people live longer. I'm sad to say that isn't the case. So what you have to do is understand the risks that you're taking when you take a drug, particularly over the medium to long term. I think what we can conclude is that over the medium term that risk looks beneficial, but we don't know that if we were to push it on for another 5 years whether that risk would actually change the risk-benefit ratio completely.